Welcome, everyone. Thank you for joining us today for the Long-Term Care, Hospital, and Inpatient Rehabilitation Facility Quality Reporting Program, Section N, Medications webinar. My name is Sharon Purcell, and I am your host and moderator today. I will now review a few housekeeping items. Due to the large number of participants on today's call, it was necessary to change our delivery platform. To ensure your audio is synchronized with the slides, we recommend using your PC to view and listen to today's presentation. If you experience audio problems on the PC and need to use the phone number and passcode provided, please download the presentation from the Materials button and follow along using the downloaded version of the presentation. This webinar is being recorded today. It will later be posted to the CMS LTCH and IRF Quality Reporting Program web pages. Closed captioning is enabled and will appear at the bottom of your screen. The audio can be controlled using the speaker icon on your computer taskbar in conjunction with the audio control on the webinar platform. The phone lines will be on mute for the duration of the presentation. If you are having trouble with the web interface, please submit those types of questions via the Ask button. Responses to these types of technical questions can be accessed by clicking on the Q&A button. If you have a question regarding the materials being presented at any point throughout today's presentation, please submit your questions to the LTCH and IRF Quality Reporting Help Desk. For LTCH providers, LTCH quality questions at cms.hhs.gov. For IRF providers, IRF.questions at cms.hhs.gov. Also, if you would like to download today's presentation, click the Materials button located on the left of your screen to access the slides. To access the shared files. Training materials can also be downloaded from the Download section of the LTCH and IRF Quality Reporting Program web pages. The Download section is at the bottom of the training web page. A disclaimer has been provided for your review. Medicare policy changes frequently, so please refer to the links provided in the presentation for the most current version of all source documents. We encourage you to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their contents. Now I'd like to introduce today's speaker. Presenting the LTCH and IRF Quality Reporting Program, Section N, Medications, is Terry Ng. Terry is a public health analyst in the Quality Measure and Policy Program in RTI's Division of Health Services and Social Policy Research. Since joining RTI, Terry has worked on several CMS projects. Terry currently serves as the Long-Term Care Hospital LTCH lead for the development and maintenance of symptom management measures project funded by CMS. This project is focused on the development, maintenance, and evaluation of quality measures for post-acute care settings to develop and implement quality measures for the LTCH Quality Reporting Program. In addition, Terry is the RTI lead for the drug Regimen Review Quality Measure and a member of the analytical teams for the evaluation of the initiative to reduce avoidable hospitalizations among nursing facility residents with the Centers for Medicare and Medicaid Innovation, where she conducts semi-structured interviews with skilled nursing facility leadership and clinical staff as the Missouri State lead. Terry has extensive clinical nursing leadership experience in surgical, clinical care, cardiovascular, and medical nursing at Brigham and Women's Hospital. On slides 8 and 9, in this slide deck, it contains a reference list of acronyms that will be used throughout today's presentation. We are pleased to have such an experienced and knowledgeable speaker present on today's webinar. Terry, thank you for being here today. It is now my pleasure to turn the session over to the presenter. Terry, the floor is yours.
Thank you, Sharon, and thank you all for joining us this afternoon. The purpose of today's webinar offered by the Centers for Medicare and Medicaid Services is to prepare you to assist your organization in understanding requirements of the LTCH and IRF Quality Reporting Program, Section N medications. Before we begin, I encourage you to submit your questions to the LTCH and IRF Quality Reporting Help Desks. They are referenced on slide 4. The drug regimen review conducted with follow-up for identified issues, quality measure, is important and critical to the care of post-acute care patients, as potential and actual patient medication errors are prevalent among post-acute care settings and often occur during transitions in care. As we know, medication errors can lead to medication-related adverse reactions, emergency department visits, and rehospitalization, and affects the patient's health, safety, and quality of life. The drug regimen review is intended to improve patient safety in IRF and LTCH patients by identifying and addressing potential and actual clinically significant medication issues at the time of patient admission and throughout the patient's stay. In the next hour, I will provide an overview of the new Section M medication data elements that have been added to the IRF-PAI and long-term care data set, explain how to code them, provide practice scenarios, and explain how the quality measure is calculated. I'll use the terms data items and data elements interchangeably. At the completion of this webinar, you'll be able to state the intent of Section N, articulate the purpose of the new items and what the coding options are, apply the coding instructions to accurately code practice scenarios, and describe the elements of the new drug regimen review quality measure. So on the first slide, slide 13, drug regimen review conducted with follow-up for identified issues. The drug regimen review conducted with follow-up for identified issues is an assessment-based, cross-setting process quality measure adopted to meet the requirements on the Improving Medicare Post-Acute Care Transformation Act, IMPACT Act, domain of medication reconciliation. On the next slide, you will see the calendar for implementation. This process measures data is currently being collected by home health agencies since January of 2017. The long-term care hospital QRP began data collection on July 1st, 2018, and the IRF and SNF QRPs will begin data collection on October 1st, 2018. There are 2 drug regimen review items that you will complete at admission, and we're going to go through all the terms used in the items in a few minutes. The drug regimen review admission data elements require that you document whether the IRF and LTCH provider conducted a drug regimen review upon the patient admission and whether clinically significant medication issues were addressed in a timely manner when identified. On slide 16, new item 2005, the drug regimen review single discharge data element is to document whether PAC providers conducted a drug regimen review upon the patient admission and whether clinically significant medication issues were identified and addressed in a timely manner when identified throughout the patient's stay. This discharge item includes the entire stay, A point of emphasis, admission through discharge. This item has been added to the IRF-PAI discharge assessment and the long-term care data set planned, unplanned, and expired assessments. In the next few slides, we'll go through some critical definitions that you will need to understand in order to accurately code the drug regimen review data elements. A drug regimen review includes medication reconciliation, a review of all medications a patient is currently using, and a review of the drug regimen to identify and, if possible, prevent potential clinically significant medication adverse consequences. So what medications are included for the drug regimen review? The drug regimen review includes all medications prescribed and over-the-counter, including nutritional supplements, vitamins, and homeopathic and herbal products. They are medications administered by any route. The drug regimen review also includes total parenteral nutrition and oxygen. However, although we say that all medications are included, this is in the context of identifying potential or actual clinically significant medication issues that have reached the level of requiring timely communication with a physician or physician designee for recommended or prescribed actions for follow-up by midnight of the next calendar day. Recently, we've received a help desk question regarding, is a nutritional supplement, such as a product that you may be all familiar with, included on a patient's meal tray, considered a nutritional supplement for the purposes of coding the drug regimen review data elements? Whether a nutritional supplement is considered a medication will depend on whether or not, in the clinician's judgment, warrants communicating with the physician or physician designee and completing a prescribed or recommended action by midnight of the next calendar day. On the next slide, we provide a definition of a clinically significant medication issue. A clinically significant medication issue is a potential or actual issue that, in the clinician's professional judgment, warrants physician communication and completion of prescribed recommended actions by midnight of the next calendar day at the latest. This slide depicts examples of potential or actual clinically significant medication issues. Please read along with me. It may be medication prescribed despite medication allergy noted in the patient's medical record. It might be adverse reactions to medications. It might be ineffective drug therapy. It may also be drug interactions, such as serious drug-drug, drug-food, and drug-disease interactions. It may also be duplicate therapy. For example, a generic name and a brand name equivalent drugs are co-prescribed. It might be medication that is related to the wrong patient, the wrong drug, wrong dose, wrong route, and time errors. It may also be an omission, drugs missing from a prescribed regimen. Or it might be non-adherence on the part of the patient, which might be purposeful or accidental. Other examples include use of a medication without evidence of adequate indication for the use. It may also be presence of a medical condition that may warrant medication therapy. Example, a resident with primary hypertension does not have an antihypertensive medication prescribed. I've observed that one of the challenges providers are having is determining if and when a medication issue is a potential or actually clinical significant medication issue. I'd like to emphasize that any of the aforementioned examples must reach a level of clinical significance that warrants notification of the physician designee for orders or recommendations by midnight of the next calendar day, at the latest, to be considered a potential or actual clinically significant medication issue. Determining if very timely communication and action is needed is key in determining whether the issue is a potential or actual clinically significant medication issue. Any circumstance that does not require immediate attention is not considered a potential or actual clinically significant medication issue for the purpose of the drug regimen review items. Two-way communication is essential for completing the drug regimen review data elements accurately. Two-way communication means communication to the physician or physician designee to convey an identified potential or actual clinically significant medication issue or issues and a response from the physician to convey prescribed recommended actions in response to the medication issue. In order to meet the requirements of the measure, you need to communicate and convey the information to the physician, and you need to have received a response from the physician so that you can then address the issues. This is two-way communication. This next slide shows examples of communication that may be used in your facility to contact the physician or physician designee. It might be in person, by telephone, voicemail, electronic means, fax, or any other means that appropriately conveys the message of the patient's status. We have received questions from providers asking how is a physician designee defined and where can you find that information. The role of physician designee is defined by federal and state licensure regulations, and we suggest that you refer to these regulations to determine which clinicians are licensed to act as physician designees. The next definition I'd like to go over is, what does medication follow-up mean? Medication follow-up is the process of contacting a physician to communicate an identified medication issue and completing all physician-prescribed recommended actions by midnight of the next calendar day at the latest. The next section will go through some coding guidance and practice some scenarios. In order to code the drug regimen review items, you are going to need to refer to and review a number of the patient's medical record sources for this information. Where are you going to find the information essential to code these three items? Medical record sources include medical records received from facilities where the patient received health care, patient's most recent history and physical, transfer documents, discharge summaries, medication lists and records, clinical progress notes. Other sources as available. Recently, we were asked if using information from an incident or an unusual occurrence report was an appropriate source for coding the data items. This would be an example of one source of information that might be helpful in coding the items. In addition to medical record sources, discussions, including discussions with the acute care hospital, other staff and clinicians responsible for completing the drug regimen review, the resident, and the resident's family or significant other may supplement and or clarify information gleaned from the resident's medical records. Your facility may decide to use a specific or central means of gathering this data to make it efficient to locate information relevant for coding this measure. Another frequently asked question for coding the DRR data elements is what needs to be documented in the medical record. The information needed to code the item should be recorded in the patient's medical record. The drug regimen review process is a multidisciplinary team review of the patient's medications. The Centers for Medicare and Medicaid Services does not provide guidance on who can or cannot code the drug regimen review items. You should refer to your facility, federal, and state policies and procedures to determine which IRF and LTCH staff members may complete a DRR. As I said, each facility determines their policies and procedures for completing the assessments, and each facility provides patient care according to their unique characteristics and standards. Another recent help desk question has been, does it have to be a pharmacist who completes the drug regimen review? The answer is no. Who completes the drug regimen review, as indicated on this slide, is contingent upon your facility's policies and procedures, applicable federal and state policies that may apply, and the unique characteristics and standards for your patient population. The next slide shows the three data elements. So on the admission assessment, we have N2001. This identifies if a drug regimen review was conducted upon admission and if the clinician identified any potential or actual clinically significant medication issues. Also on the admission assessment is N2003, which identifies if the facility contacted a physician or physician designee and completed all physician or physician designee prescribed recommended actions by midnight of the next calendar day in response to all potential or actual clinically significant medication issues identified upon admission. The discharge assessment includes N2005, and this identifies if the facility contacted a physician or physician designee and completed all physician or physician designee prescribed recommended actions by midnight of the next calendar day each time potential or actual clinically significant medication issues were identified throughout the stay. Now we will turn to a description of each data element for the drug regimen review. As previously shown, there are two admission assessment data items to complete on the IRF-PAI and LCDS. And as I stated, N2001 identifies whether a drug regimen review was conducted upon admission or as close to the actual time of admission as possible, and whether the clinician identified any potential or actual clinically significant medication issues. There are three choices for coding N2001, which I will review. Steps for assessment. This first step is to complete a drug regimen review upon admission or as close to the actual time of admission as possible to identify any clinically significant medication issues. The second step is to review the medical record sources to determine if a drug regimen review was conducted upon admission. And the medical record sources are the ones that I covered on the previous slide. N2001 asked, did a complete drug regimen review identify any potential or clinical significant medication issues? You're going to code 0 no if no clinically significant medication issues were identified during the drug regimen review. You're going to code 1 yes if one or more clinically significant medication issues were identified during the drug regimen review. And you will code 9 not applicable if the resident was not taking any medications at the time of the drug regimen review. A dash value is a valid response for this item. However, the Centers for Medicare and Medicaid Services expects dash use to be a rare occurrence. There are skip patterns associated with N2001. So if you code 0, no issues found, then you're going to skip to O0100, special treatments, procedures, and programs. If you code N2001 as yes, issues found during review, then you're going to continue to N2003, medication follow-up. If you code N2001 9, non-applicable, patient is not taking any medications, then you are also going to skip to O0100, special treatments, procedures, and programs. So now we'll go over some practice some coding scenarios. The admitting PAC nurse reviewed and compared the acute care hospital discharge medication orders and the PAC physician's admission medication orders for Mrs. W. The nurse interviewed Mrs. W., who confirmed the medication she was taking for her current medical conditions. Upon the nurse's request, the pharmacist reviewed and confirmed the medication orders as appropriate for the patient. As a result of this collected and communicated information, the registered nurse determined that there were no identified potential or actual clinical significant medication issues. How would you code N2001 on the admission assessment? Did a complete drug regimen review identify potential clinically significant medication issues? You would code this scenario 0, no issues found during the review, 1, yes, issues found during review, 9, not applicable, or enter a dash. And I'm sure everyone on this call got the right answer, and the answer is a 0, no issues found during review. You're going to code 0, no issues found during the review because the admitting nurse reviewed and compared the patient's discharge medication records from the acute care hospital with the physician's admission medication orders, collaborated with the pharmacist, and interviewed the patient. The nurse determined that there were no potential or actual clinically significant medication issues. In the next scenario, Mr. C was admitted to a post-acute care setting after undergoing mitral valve replacement. The acute care hospital discharge information indicated that Mr. C had a mechanical mitral heart valve and was to continue receiving anticoagulant medication. While completing a review and comparison of the patient's discharge healthcare records from the acute care hospital with the PAC physician's admission medication orders, an RN noted that the admitting physician ordered the patient's anticoagulation medication to be held if the international normalized ratio, INR, was below 1.0. However, the physician's admission note indicated that the desired therapeutic INR parameters for Mr. C was 2.5 to 3.5. The RN questioned the INR level listed on the admitting physician's order based on the therapeutic parameters of 2.5 to 3.5 documented in the physician's admission note. This prompted the RN to call the physician immediately to address the issue. How would you code N2001 on the admission assessment for this scenario? Again, you have similar responses. A, 0, no issues found during review. B, 1, yes, issues found during review. C, 9, not applicable. Patient is not taking any medications. Or D, enter a dash. And B, 1, yes, is the correct answer. And you would code this scenario 1, yes, issues found during the review because the admitting nurse reviewed and compared the patient's discharge healthcare records from the acute care hospital with the physician's admission medication orders and admission note, and the nurse identified a discrepancy between the physician's documented INR level of 2.5 in the admission note and the physician's order to hold anticoagulation medication for an INR level of 1.0. The nurse considered this discrepancy to be a potential clinically significant medication issue that could lead to potential clotting issues. Next, we'll go over N2003, medication follow-up, which is also on the admission assessment. N2003 identifies whether the facility contacted a physician and completed all physician-prescribed recommended actions by midnight of the next calendar day in response to all potential or actual clinically significant medication issues identified upon admission. N2003 asks, did the facility contact a physician or physician designee by midnight of the next calendar day and complete prescribed recommended actions in response to the identified potential or actual clinically significant medication issues? And you are going to code this data element either 0, no, or 1, yes. This item is completed if a potential or actual clinically significant medication issue was identified during the admission drug regimen review. The steps for addressing this second DRR admission question are: to accurately code N2003, you need to determine whether two-way communication between the clinician and the physician was completed by midnight of the next calendar day and all physician-prescribed recommended actions were completed by midnight of the next calendar day. This criteria needs to be met for all potential and actual clinically significant medication issues that were identified upon admission. You're going to code N2003 0 no if all identified potential or actual clinically significant medication issues were not completed by midnight of the next calendar day. You'll code this data element 1, yes, if the two-way communication and completion of the prescribed recommended actions occurred by midnight of the next calendar day after the potential clinically significant medication issue was identified. As I previously mentioned, a dash is a valid response for this item. However, CMS expects dash use to be a rare occurrence. I'd like to share a coding tip with you. If the physician prescribes, recommends an action that will take longer than midnight of the next calendar day to complete, then you can still code this item N2003 1 yes if by midnight of the next calendar day the facility has taken the appropriate steps to comply with the prescribed recommended action. An example of a physician-recommended action that would take longer than midnight of the next calendar day to complete might be a physician writes an order instructing the clinician to monitor the medication issue over the next 3 days and call if the problem persists. I'd also like to share with you a couple of examples of when you would code when appropriately coding N2003 0 no. One example is a clinician did not communicate all identified clinically significant medication issues to the physician or physician designee until after midnight of the next calendar day. You would code this data element 0 no. Another example would be a clinician communicated all identified clinically significant medication issues to the physician by midnight of the next calendar day, but the clinician did not receive a response from the physician to communicate prescribed recommended actions until after midnight of the next calendar day. So this would be appropriate to code and should be coded N2003 0 no. The next slide shows examples of by midnight of the next calendar day. In example 1, a clinically significant medication issue is identified at 10 a.m. on September 12, 2018. The physician or physician designee prescribed recommended action is completed on or before 11:59 p.m. on September 13, 2018. On the right side of the screen, you'll see example 2. A clinically significant medication issue is identified at 11 p.m. on September 12, 2018. The physician's or physician designee prescribed recommended action is completed on or before 11:59 p.m. on September 13, 2018. And as I've mentioned, if the physician or physician designee recommends an action that will take longer than midnight of the next calendar day to complete, then code 1 yes should still be entered as long as by midnight of the next calendar day the clinician has taken the necessary measures to comply with the recommended action. And I've also gone over this coding tip as well. If the physician or physician designee recommends an action that will take longer than midnight of the next calendar day to complete, then code 1 yes should still be entered as long as by midnight of the next calendar day the clinician has taken the necessary measures to comply with the recommended action. And as you can see in the example, the physician writes an order instructing the clinician to monitor the medication issue over the weekend and to call if the problem persists. And another coding tip is if the physician or physician designee communicates that no actions are necessary regarding the reported issues, then you would code 1 yes should still be entered as long as all communications took place before midnight of the next calendar day. In the next slide, we show how to code the data elements when the DRR is not completed. If the DRR was not completed upon admission, then N2001 and N2003 are coded with the dash. And as I've already indicated, dash value is a valid response for this item. However, CMS expects dash use to be a rare occurrence. We have received the following question as depicted on this slide. If a physician orders medications on admission and the pharmacist contacts the physician to resolve the question potential issue, is this still considered an issue? And the answer is, if the issue was determined to be clinically significant, then the issue identified by the pharmacist and communicated to the physician and resolved by midnight of the next calendar day meets the requirements for coding N2001 1 yes issues found during drug review and N2003 1 yes medication follow-up on the admission assessment. I hope these questions and answers that we're providing through the webinar are helpful, because it's been fortunate that providers have submitted these really excellent questions, and so it's great to be able to share them with you today. If a facility-based physician designee performed the drug regimen review, identified a medication issue, and addressed it without needing to communicate with another physician designee, how should N2001 and N2003 be coded? In this scenario, the physician designee identified and resolved the medication issue, and therefore it did not require two-way communication with facility staff. As we've previously mentioned, the definition of a clinically significant medication issue requires the identification of a medication issue that warrants contacting a physician or physician designee, i.e. two-way communication, in a timely manner and addressing all physician or physician designee prescribed recommended actions by midnight of the next calendar day at the latest. Now we'll move on to practicing some coding scenarios for N2003. And as we go through this, I'll be asking you to code both N2001 and N2003. Mr. B was admitted to a PAC with an active diagnosis of pneumonia and atrial fibrillation. The acute care facility medication record indicated that the patient was on a 7-day course of antibiotics, and the patient had 3 remaining days of this treatment plan. The PAC pharmacist, reviewing the discharge records from the acute care facility and the PAC admission medication orders, noted that the patient had an order for an anticoagulant medication that required INR monitoring as well as an antibiotic. On the date of admission, the PAC pharmacist contacted the PAC physician caring for Mr. B and communicated a concern about a potential increase in the patient's INR with this combination of medications, which placed the patient at greater risk for bleeding. The PAC physician provided orders for laboratory testing so that the patient's INR levels would be monitored over the next 3 days starting that day. However, the nurse did not request the first INR laboratory test until after midnight of the next calendar day. So how would you code N2001 on the admission assessment? Did a complete drug regimen review identify potential clinically significant medication issues? And your responses are the same as previous scenarios. A, 0, no issues found during review. B, 1, yes, issues found during review. C, 9, not applicable, patient is not taking any medications. Or D, enter a dash. And as you've all been so consistent in responding to these questions accurately, I'm sure, this one you've also coded accurately, which is B1, yes, issues found during the review. How would you code N2003 on the admission assessment? Did the facility contact a physician or physician designee by midnight of the next calendar day and complete prescribed recommended actions in response to the identified potential clinically significant medication issues? And your responses are A, 0, no, B, 1, yes, or C, enter a dash. And the correct response is A, 0, no. So to summarize the coding for this scenario, N2001 is coded 1, yes, issues found during review, and N2003 is coded 0, no. And the reason for this is that a potential clinically significant medication issue was identified during the DRR. The staff did contact the physician before midnight of the next calendar day, but did not complete, to the extent possible, the physician-prescribed actions related to the INR laboratory test until after midnight of the next calendar day. Now we'll move on to practice coding scenario 4, and we're going to have you think about coding N2001 and N2003 for this one. Mrs. S. was admitted to the PAC from an acute care hospital. During the admitting nurse's review of the patient's acute care facility discharge records, it was noted that the patient had been prescribed metformin. However, admission labs indicated the patient had a serum creatinine of 2.4, consistent with renal insufficiency. The PAC admitting nurse contacted the PAC physician designee to ask if this drug would be contraindicated with the patient's serum creatinine level. 3 hours after the patient's admission to the PAC physician designee provided orders to discontinue the metformin and start the patient on a short-acting sulfonylurea for ongoing diabetes management. These medication changes were implemented within the hour. So how would you code N2001 on the admission assessment for this scenario? Did a complete drug regimen review identify potential clinically significant medication issues? And your responses are the same as in previous scenarios. A, 0, no, B, 1, yes, C, 9, non-applicable, D, enter a dash. And the correct answer is B1, yes, issues found during review. How would you code N2003 on the admission assessment? Did the facility contact a physician or physician designee by midnight of the next calendar day and complete prescribed recommended actions in response to the identified potential clinically significant medication issues? And your responses are A, 0, no, B, 1, yes, or C, enter a dash. And the correct answer is B, 1, yes. So in summary, for this scenario, you're going to code N2001, 1 yes, issues found during review, and N2003, 1 yes. And the rationale for coding these responses is that the physician communication occurred and the nurse completed the physician designee prescribed actions by midnight of the next calendar day. In this case, medication had been ordered that was contraindicated for the patient's current condition. The PAC clinician's two-way communications resulted in discontinuing the contraindicated medication and replacing with an appropriate medication. Now we're going to move on to N2005. And the observation period for this item is from the date of admission through discharge. And N2005 asks, did the facility contact and complete physician or physician designee prescribed recommended actions by midnight of the next calendar day each time potential or clinically significant medication issues were identified since the admission? And your coding responses here are 0, no, 1, yes, or 9, not applicable. There were no potential or actual clinically significant medication issues identified since admission, or the patient is not taking any medications. To accurately code N2005, you are going to review the patient's medical documentation and identify all potential or actual clinically significant medication issues that were identified upon admission and throughout the patient's stay. And you will use the same medical record resources and sources that I mentioned in previous slides. The second step is to determine if both criteria were met for all potential and actual clinically significant medication issues that were identified upon admission or at any time throughout the resident's stay. Two-way communication between the clinician and the physician was completed by midnight of the next calendar day, and all physician-prescribed recommended actions were completed by midnight of the next calendar day. N2005 includes all drug regimen review information that you collected and coded from when the patient was admitted throughout that patient's stay, admission through discharge. You are going to code N2005 0 no, if all clinically significant medication issues identified upon admission or at any time throughout the patient's stay, admission through discharge, were not addressed by midnight of the next calendar day. You would code this data element 1, yes, if all clinically significant medication issues identified upon admission or at any time throughout the patient's stay, admission through discharge, were addressed by midnight of the next calendar day. And you would code this data element 9, not applicable, if there were no potential or actual clinically significant medication issues identified upon admission or throughout the patient's stay, or the patient was not taking any medications at the time of admission or throughout the stay. You also have the option of coding this data element with a dash. However, as I've mentioned several times, CMS expects dash use to be a rare occurrence. An example of coding N2005-0 no include at admission or at any time during the patient's stay, the clinician did not communicate all identified potential or actual clinically significant medication issues to the physician until after midnight of the next calendar day. You would also code this data element 0, no. At admission or at any time during the patient's stay, the clinician communicated to the physician designee all identified potential or actual clinically significant medication issues, but the physician designee did not respond until after midnight of the next calendar day. And a third example of where you would code this data element 0, no, is at admission or at any time during the patient's stay, the clinician did not complete all physician designee prescribed recommended actions for all identified potential or actual clinically significant medication issues by midnight of the next calendar day. You would code this data element 1, yes, if the facility contacted the physician and completed prescribed recommended actions by midnight of the next calendar day each time a potential or actual clinically significant medication issue was identified throughout the patient's stay, from admission to the discharge. This slide just provides a point of emphasis regarding what throughout the stay means. And it means or includes admission through and up to the time of the patient's discharge. The drug regimen review is conducted upon admission, and the clinician completes actions recommended by a physician or physician designee during a timely follow-up, which are completed each time potential or actual clinically significant medication issues are identified throughout the stay. And timely for the drug regimen review refers to midnight of the next calendar day at the latest. On the next slide, we have another question that we've received from providers. If a provider coded item N2003 as 0, no, on the admission assessment, indicating that the required follow-up action did not take place, is there a way for the facility to code N2005 as 1, yes? And the answer would be if N2003 is coded as 0, no, then N2005 must also be coded 0, no. And this means that if only one of multiple potential clinically significant medication issues at admission was not followed up by midnight of the next calendar day, the facility should code N2003 on admission as 0, no, and N2005 admission through discharge as 0, no. Even if only one of multiple medication issues was not addressed by midnight of the next calendar day, N2003 is always coded 0, no, indicating that the required follow-up did not take place for the potential clinically significant medication issue identified at admission. Now we'll move on to Scenario 5. At discharge from the PAC, the discharging licensed clinician reviewed Mrs. T's medical records, which included admission through her entire stay at the PAC. The clinician noted that a clinically significant medication issue was documented during the admission assessment. At admission, Mrs. T was taking 2 antibiotics. An antibiotic prescribed during a recent acute care hospital stay that the PAC physician had included in her PAC medication orders, and a second antibiotic prescribed to the physician upon admission that is known for a drug-induced nephrotoxicity. Mrs. T has renal disease. Mrs. T's medical records further indicated that a PAC nurse had attempted to contact the assigned PAC physician several times about this clinically significant medication issue. After midnight of the second calendar day, the PAC physician communicated to the nurse via a telephone order to administer a newly prescribed antibiotic. The nurse implemented the physician's order. Upon review of Mrs. T's medical records, the discharging nurse determined that no additional clinically significant medication issues had been recorded throughout the remainder of Mrs. T's stay. So how would you code N2001 in the admission assessment? Did a complete drug regimen review identify potential clinically significant medication issues? And your responses are A, 0, no, no issues found during review, B, 1, yes, issues found during review, and C, 9, non-applicable, patient is not taking any medications, or you would enter a dash. And the correct response is B, 1, yes, issues found during review. On slide 83, we're asking you, how would you code N2003 on the admission assessment? Did the facility contact a physician or physician designee by midnight of the next calendar day and complete prescribed recommended actions in response to the identified potential clinically significant medication issues? A, 0, no, B, 1, yes, C, enter a dash. And the correct response on slide 84 is A, 0, no. On the next slide, how would you code N2005 on the discharge assessment? In this scenario, did the facility contact and complete physician or physician designee prescribed recommended actions by midnight of the next calendar day? Each time, potential clinically significant medication issues were identified since the admission. And your responses are A, 0, no, B, 1, yes, C, 9, not applicable, or D, enter a dash. And the correct response is A, 0, no. And you're going to code this particular scenario, N2001, yes, issues found during review. You're going to code N2003, 0, no, all identified potential or actual clinically significant medication issues were not completed by midnight of the next calendar day. And you're going to code N2005, 0, no, all clinically significant medication issues identified at admission or at any time throughout the patient's stay, admission through discharge, were not completed by midnight of the next calendar day. The rationale for this coding is that coding of N2005 includes all clinically significant medication issues identified at admission or at any time throughout the patient's stay that were or were not communicated to the physician with prescribed recommended actions completed by midnight of the next calendar day. In this scenario, although no potential or actual clinically significant medication issues were identified by the nurse during the remainder of the stay, notification of the medication issue identified at admission, despite repeated communication attempts by the nurse, was not addressed by the physician designee by midnight of the next calendar day. Now we'll move on to our last coding scenario, and I'm going to ask you to code N2005. At discharge, the licensed clinician completing a review of Mrs. K's medical records identified and noted 2 clinically significant medication issues during the patient's stay. The patient's record included an order to hold the medication Mrs. K was receiving for deep vein thrombosis prophylaxis. Based on the patient's clinical status, the PAC-RN determined that the physician needed urgent notification. The day after the observed symptoms were identified and physician notification occurred, the PAC physician provided an order to resume the medication, which was carried out by the nursing staff within the hour. In addition, a licensed clinician identified a clinically significant medication issue had occurred during the admission assessment period, and the physician had been contacted on the same day. Both medication issues identified during the patient's stay were communicated and addressed by midnight of the next calendar day. There were no additional clinically significant medication issues identified during the remainder of the PAC stay. So how would you code N2001 on the admission assessment? Did a complete drug regimen review identify potential clinically significant medication issues? And your responses are similar as in previous scenarios. And the correct response is B1, yes, issues found during review. How would you code N2003 on the admission assessment? Did the facility contact the physician or physician designee by midnight of the next calendar day and complete prescribed recommended actions in response to the identified potential clinically significant medication issues? And the correct response is B1, yes. How would you code N2005 on the discharge assessment? Did the facility contact and complete physician or physician designee prescribed recommended actions by midnight of the next calendar day each time potential clinically significant medication issues were identified since the admission? And the correct response on slide 97 is B1, yes. All potential or clinically significant medication issues identified at any time throughout the patient's stay, admission through discharge, were communicated to the physician, and prescribed recommended actions were completed by midnight of the next calendar day after each issue was identified. And the rationale for coding N2001, N2005, 1, yes. All clinically significant medication issues were identified at admission or at any time throughout the patient's stay, admission through discharge, were completed by midnight of the next calendar day. Although a medication issue was identified as a clinically significant medication issue at admission, it was resolved by midnight of the next calendar day. Furthermore, the drug regimen review conducted at discharge included the entire patient's stay, admission through discharge. During the patient's stay, A second clinically significant medication issue was identified. Each time the clinically significant medication issues were identified at admission and during the stay, they were communicated to the physician and resolved through completion of prescribed recommended actions by midnight of the next calendar day. The next few slides will present the drug regimen review conducted with follow-up for identified issues, quality measure, and how it will be calculated for the purposes of the IRF and LTCH QRPs. The drug regimen review conducted with follow-up reports the percentage of patient stays in which a drug regimen review was conducted at the time of admission, and timely follow-up with a physician occurred each time potential and actual clinically significant medication issues were identified throughout the stay. I'm going to walk you through slide 102 because it's a little dense or hard to see, but the drug regimen review is a process quality measure that is calculated as a facility-level observed score. To calculate the percentage of patients that successfully met the drug regimen review measure criteria, we set up a fraction. The fraction is comprised of the numerator and the denominator. The denominator for the DRR measure is the number of patient stays in the selected time window. The numerator is a subset of patients in the denominator. For the drug regimen review measure, the numerator includes patient stays in the denominator in which the total number of stays in the denominator meeting each of the following two criteria. 1, the facility conducted a drug regimen review on admission, which resulted in one of the three following scenarios. No potential and actual clinically significant medication issues were found during the review. In other words, N 2001 equals 0, or potential and actual clinically significant medication issues were found during the review, N 2001 equals 1, and then a physician was contacted and prescribed recommended actions were completed by midnight of the next calendar day, N 2003 equals 1, or the resident was not taking any medications, N 2001 equals 9. The second criteria is appropriate follow-up occurred each time a potential or actual clinically significant medication issue was identified during the stay, N 2005 equals 1, or no potential or actual clinically significant medication issues were identified since the admission or the resident was not taking any medications, N 2005 equals 9. You then would divide the facility's numerator count by its denominator and multiply by 100 to determine the rate. The DRR quality measure is a process measure and therefore is not risk-adjusted nor stratified. There are no denominator exclusions. Slide 104 summarizes the items that are included in the quality measure, which I've already reviewed. So it's N 2001, drug regimen review, N 2003, medication follow-up, and N 2005, medication intervention. If the dash is entered for any of these three items, the patient stay will not be included in the numerator count, but the patient stay will be included in the denominator count. In summary, the drug regimen review is new to Section N, medications of the LTCH Care Data Set 4.0 and IRF-PAI version 2.0, and includes the following items, which I've reviewed. This measure assesses whether PAC providers conducted a drug regimen review upon the patient's admission and throughout the patient's stay, and whether any potential or actual clinically significant medication issues identified were addressed in a timely manner. The final two slides for today's webinar present important information from the recently published Federal Register Final IRF and LTCH rules that we thought would be useful. Two quality measures were removed from the IRF and LTCH QRPs. The first one, National Healthcare Safety Network, facility-wide inpatient hospital on-site methicillin-resistant Staphylococcus aureus bacteremia outcome measure, beginning with the fiscal year 2020 IRF and LTCH QRPs. Beginning October 1st, 2018, IRFs and LTCHs will no longer be required to submit data on this measure for the purposes of the IRF and LTCH QRPs. The second measure that's been removed is percent of residents or patients who were assessed and appropriately given the seasonal influenza vaccine, NQF0680, beginning with the fiscal year 2021 IRF and LTCH QRPs. Beginning October 1st, 2018, IRFs and LTCHs should enter any of the valid codes or a dash for 00250A, 00250B, and 00250C until the next IRF-PAI and LTCH care data set is released. One additional measure was removed from the LTCH QRP, and that is the National Healthcare Safety Network Ventilator-Associated Event Outcome Measure, beginning with the fiscal year 2020 LTCH QRP. Beginning October 1st, 2018, LTCHs will no longer be required to submit data on this measure for the purposes of the LTCH QRP. On the last slide, CMS also finalized in the 2019 IRF and LTCH rule an expansion of the methods by which IRFs and LTCHs are notified of noncompliance with the requirements of the IRF and LTCH QRPs for a program year, and how CMS will notify IRFs and LTCHs for a reconsideration decision. For IRFs only, data on the 4 assessment-based functional outcome measures will be displayed in calendar year 2020. And now I'll turn it back to you, Sharon.
Thank you, Terry. Great. Now, before we wrap up today's event, I'd like to thank Terry for the valuable knowledge that she shared during today's webinar. I also want to let you know that the full version of slides, including the answers to the polling questions, as well as a recorded version of this webinar, will be posted, and we will send an email notifying you when and where those items have been posted. And as a last reminder, please submit your questions regarding today's webinar to the LTCH and IRF Quality Reporting Help Desk. This concludes Quality Reporting, Section M, Medications webinar. Thank you all very much for attending.
And this concludes today's webinar. Thank you for attending.